happy to see my mentor, Professor Namrata Sharma ma'am, also attending this conference. And so I'm really happy to be presenting my presentation on finding the sweet spot. So this presentation is basically for all the Lenticule users to basically assess clinically and optimize your energy settings or your machine to perform optimally in all the cases as far as you can. So I'll briefly touch upon this differences between different machines, but I only want to highlight the fact that the Z8 works with a very high repetition rate that is very different from all the other platforms that we have. It has a microscope or machine integrated OCT which really guides in a lot of ways during your surgeries and also in your rescue procedures. It has an automated centration now with the Galilei Color C being integrated, and you do have the option of 2 guiding tunnels. For me, in my machine, this energy per pulse is actually really very low, but that depends from machine to machine. It varies because of the glass cutting threshold of each machine being different. So basically, the concept of low energy laser is being used by Zimmer for the last maybe 13 or 14 years. I don't know the long history, but the flap of Zimmer was always made on this low energy platform itself, which used to give a very smooth cut, and the reason for that is minimum dissipation of energy and lesser corneal injury. So there's a lot of talk about the pulse energy or the spot size and all these things. Well, this article by Professor Wagner et al. Really put things in perspective, where you see there are a lot of laser parameters that go in to create your desired effect. So, in fact, like the focal diameter or the spot shape are things that are really not quantifiable or modifiable by us. So it's really a very complex interplay of a lot of factors. But then pulse energy is something that we can easily understand and modify, which is why we talk a lot about it. So pulse energy is really important in terms of determining the surrounding tissue interaction and reaction. But the question is that emitted pulse energy is not the same as the absorbed pulse energy at the laser focus in the cornea. And this is a thing that we must keep in mind while we are juggling with all these parameters and thinking about all this dose, density, fluence and all. Really, are we measuring the absorbed pulse energy at the laser focus in the cornea? Because there are a lot of factors that determine that. So with that in perspective, with this concept of energy being absorbed at the laser focus, I will delve right into the clinical science of how you can improve your outcomes in your own machine. Because unfortunately, not all of us have the complex tools and the means to actually use all these tools that we have discussed over the past 1.5 days and we'll discuss on the next day as well. We don't have all of that. So we need to go by some clinical science and understand how our machine is functioning and how we can push towards better results. So this is my initial curve, and when I started off, my career journey was not very satisfying. Honestly, it was the initial curve. I was also a newer surgeon to lenticule surgery, and I started off on a new machine. And you can see this heterogeneous bubbles that formed in the cuts. And of course, the outcomes were not very satisfying. And at this point, I was actually using an energy that was 41% and 44%, which was what was prescribed at the time to me as a beginner. But I thought that it was excessive and unpredictable with a lot of gas bubbles and delayed recovery. And then we got to thinking that there was a pattern of OBL that was forming, where we realized that when we move from the center to the periphery, that pattern slightly changes. And what what we realized was that we were in an energy overkill, so to say. So this is just an oversimplification of the concept. But then what we did is that we worked with Zimmer to actually change the energy per pulse as you go along from the center to the periphery within a particular cut. So I don't want you to focus on these absolute values because they are not correct. But what I want to tell you is that it is the only machine that can actually continuously change the energy per pulse that it is delivering even during a single cut. So it's not between two eyes, it's not between anterior and posterior cut, it's just the posterior cut, and it can achieve that. And that got things really going for us, and we were able to optimize our trajectories to get a homogeneous pattern of dissection, and that improved our outcomes tremendously. And this was the point where I was quite satisfied with my outcomes, and I was happily continuing my journey of lenticule surgery when I realized that I could go even better. At this point, I was actually achieving CDVA at day 1 in about 64% patients. But then, the journey to optimization continued, and now we are at a point where we are utilizing much lesser energy than what I was earlier doing. And now between March 2024 to September 2024, 94% of my patients do achieve 2020 or better on the day 1 itself. And this huge jump is something that I want to share the journey of. So it's a step-by-step approach to analyzing your lenticule cut and achieving the lowest possible energy levels. So there are a few things that I want you to focus on. The first is the venting channel. Now the venting channel plays a kind of a googly for us in this particular machine, because it's like a pressure release valve. When you have too much of bubbles, venting channel will open and the bubbles will egress out of it. So if you have an open venting channel with excessive bubbles, you should think that you are already in a state where you are giving too much energy. And the incisions would open up with minimal or no burping of gas. The lenticule cuts are opaque, heterogeneous, but you will not find any retained gas because all of that has egressed out of the venting channels. So this is a state where you can obviously see that you are on a high laser power. And soon you would move to reducing your settings. Now when you reduce your settings, what will happen first is that the venting channel will stop opening. And what that leads to is something which most of the lenticule procedures show. When you open your incision, you will see egress of gas bubbles, which were trapped in the anterior and posterior cuts. So when you see this egress of these bubbles, that means that you are in a moderate energy range, where basically you are not at such a high energy that the venting channel is opening, but the energy is not low enough. So it's a smooth cut. The incision opens with burping of gas. The lenticule cuts are less opaque, they are homogeneous, but there is retained gas in the cuts. And the pass of the instrument is smooth, is super smooth. There is absolutely no resistance. I could actually just pull it out. But then this energy level is quite high. So when you are getting it too smooth, probably in the post-operative period, you might encounter some reaction. So this is not the state where you want to be, although this is going to be the long learning curve where you will spend most of the time.
Prakhyat, sorry, there is a live surgery patient who the patient is. Can you sum it up, please?
Yeah.
Anything which is different so that so that we have some.
So when you just 30 seconds, sir. So when you reach the ideal power for your machine, which is for me is this, then you reach a point where your cuts are super smooth, but there is a uniform stickiness or a uniform resistance to your instrument. And that is the point where you achieve the sweet spot. So you're not aiming for a completely cut or a completely separated lenticule. You're aiming for a point where it's a uniform stickiness with no gas burping out of your incisions, and that would be probably close to what your ideal threshold is. You can go too low in power while experimenting, and you might end up with a situation where it is uncut, but then there are rescue procedures which can easily rescue your case. I think that's the long and short of it. Thank you.
Thank you.